Hi, everyone. Thank you for joining our SSCD webinar today. My name is Megan Donnelly. I am the Director of Health Communications at the Celiac Disease Foundation, and I'm really excited for this presentation about NASPGHAN and the Single Topic Symposium for Celiac Disease, which took place last month. This is a little bit of a different presentation than our normal ones. It's presented by speakers from who attended NASPGHAN and from the webinar committee. So we're really excited to introduce them. So so here's our agenda. We're just going to share the highlights of NASPGHAN and the Single Topic Symposium, and then please stay till the end because we have a little bit of a preview for the 2026 webinars. Okay, and here are our speakers. So first we're going to have Jacqueline Quinlan, who is a member of the celiac team at Boston Children's Hospital. She leads the celiac dietitian team, and she also works closely with patients with IBD. Then we have Dr. Jackie Jossen, who's a pediatric gastroenterologist and assistant professor at Columbia University's Celiac Disease Center. Then we'll have Sharon Weston, who is a senior clinical nutrition specialist at Boston Children's Hospital, who also works with patients in GI and endocrine departments. She's the co-facilitator of the newly formed NASPGHAN Culinary Medicine Special Interest Group. So we'll hopefully get a little bit of a preview of that. And then finally, Dr. Telly Chung, who is a, excuse me, pediatric gastroenterologist at UCSF's Benioff Children's Hospital, and he has a special interest in working with children with celiac disease. In his research, Telly is exploring how social adversities affect children with celiac disease. So with that, I will turn it over to Jacqueline, our first speaker.
All right. Thanks, Megan. All right, let me just. Can you see my slides all right?
Yes.
Awesome. Okay. So, we are, as Megan said, kind of going through some highlights, and I was honored to be able to speak at the Single Topic Symposium. It was a really wonderful and enriching day, just kind of hearing everybody's different talks, different areas of specialty and study. So, as kind of a dietitian who was part of the day and organization, I was involved in two different sessions. One was a lunch and learn session, which was a little bit more kind of informal conversation, and then also part of the Single Topic Symposium modules. So I kind of combined both of the content from both of those sessions for us to go through and in an abbreviated version. So kind of starting off just reviewing label reading and what that looks like in the gluten-free space. And so we did a lot of talk at the lunch and learn session just about grains that contain gluten and how to avoid them and what to look for in ingredients list. And so I think something that was maybe helpful just to kind of explain as a way that when we're teaching it to patients, something that we use in our clinic is this brow checklist and kind of thinking through barley, rye, oats, and wheat, and thinking, is the product labeled gluten-free? If not, these are the ingredients that patients are looking for, and that we're kind of educating them to look for when reading the ingredients list. We also talked about the regulatory agencies that regulate our food supply and kind of the differences where they fall within these labeling regulations. So we talked about how the FDA oversees the Food Allergen Labeling Consumer Protection Act. And so this covers that contains statement and how that includes the top 9 allergens. So it's really relevant for looking if a product contains wheat, but it does not include barley and rye. So kind of talked about the importance of then reviewing labels for those ingredients as well. And we also talked about how the USDA regulates meat, poultry, and eggs. And so when we're thinking about allergen labeling for those foods, that's slightly different. All of the ingredients in the formulation of those foods must be declared by the plain name, but the allergen law doesn't necessarily apply as the same way that it does for FDA regulated products. We also briefly touched upon testing and verification, so how manufacturers are not required to test for the presence of gluten in ingredients, but the product can be labeled gluten-free if the manufacturer can ensure that the products meet those requirements. So, sorry, I think I said that backwards, but they're not required to test, but then there are the testing uh, availability. So the LISA testing is something that can be used. It's common. It does have limitations. There's variability between the different test kits and thought to be some poor accuracy, especially when thinking about fermented and hydrolyzed foods. And so based on how things are labeled and consumer feedback, the FDA may perform food label reviews and also follow up on consumer and industry complaints. We also talked a little bit about gluten-free certifications. And so there's many different certification labels out there. These are just a handful of them listed at the top of the screen. And so for a product to be labeled as certified gluten-free, there's typically third-party involvement for the product. And these products have strict standards, and some are all of them meet less than 20 parts per million criteria. Some are even less than that. Some are less than 10 parts per million, less than 5 parts per million. Typically, products with these labels tend to be a little bit more expensive, just with that third-party involvement and verification. And so there's many organizations in North America that are involved and have their own labeling and criteria. And as I mentioned, this criteria can differ based on the different labels, but at the end of the day, they all meet that FDA criteria to be less than 20 parts per million. We talked a little bit about advisory statements. So these are those may contain or processed in the same facility as statements. And we discussed how, they're voluntary. And so just because they have, just because a product has these statements doesn't necessarily mean that it's something that's contaminated. And so all manufacturers are required to follow good manufacturing practices. It's a regulation set by the FDA, and that's to prevent unintentional ingredients from ending up in food products. We talked a little bit about oats throughout both of the presentations. They're usually a pretty hot topic when talking about the gluten-free diet. So kind of main takeaway points were that oats are a higher risk food for cross-contact because how they're grown and manufactured with wheat and barley in the fields. It's recommended that patients with celiac disease only consume oats that are labeled as gluten-free. We also briefly went over purity protocol versus mechanical and optical sorting methods that have been developed to get gluten-free oats, and how if a patient has persistent symptoms or maybe elevated serology, we would consider removal of all oats from their diet. Also considering reaction to avenin is something that we discussed. Thinking through how some patients, if they're still symptomatic, maybe it could be reaction to the avenin protein rather than actual oat issue, and perhaps over time might even find some improvement in those symptoms if they continue to consume the oats. And this is just a graphic that it was made from a paper from the Dietitians in Gluten and Gastrointestinal Disorder position paper on gluten-free, on oats in a gluten-free diet. And so if a person with celiac disease was continuing to eat gluten-free oats and having symptoms or elevated serology, considering the frequency at which they're eating oats and the access to the different brands that maybe they're choosing, also the severity of their symptoms, their health status, you might consider a change in the brand of oats versus complete elimination of oats from their diet. And then in the various timeframes proposed, think about how to monitor symptoms, serology, maybe even intestinal biopsy, so kind of collaboratively with the GI team. And then if symptoms or antibodies persisted after switching brands, then considering that complete elimination, or kind of going back to the drawing board, is there another source of gluten in the diet that was maybe missed initially? Cross-contamination was something that was also discussed. So just kind of going over definitions where accidental transfer of gluten to gluten-free foods is what we think of when talking about cross-contamination and kind of just setting the stage that small amounts of gluten can trigger symptoms for a person with celiac disease. And so it was interesting as a group, we kind of in the lunch and learn session sat down and looked and said, like, okay, so, you're somebody who with celiac disease at this party, this is kind of the spread at the table, and pointed out all of the different areas where cross-contamination could be a concern. And, there were a lot of ideas and a lot of discussion around it. And so I think just varying comfort levels with different things that are on the table here. And then we talked about how to manage cross contact and really just trying to avoid visible gluten on surfaces and kind of good hand hygiene, trying not to use shared utensils, preparing gluten-free items first. So just some strategies for managing cross contamination in a shared kitchen. And then also talking about how for specific maybe items or in the kitchen, like pots and pans, just washing very well with soap and water, not needing dedicated pots and pans, recommending a separate pasta colander and a gluten-free toaster recommended, maybe not a requirement, using best judgment around those things. If it's something that's relatively clean, maybe you can throw some tin foil down versus something that's saturated in crumbs. You can kind of use your best judgment on shared toasters. And then we also talked about double dipping, where separate containers versus squeezable containers versus just being mindful of not double dipping in the same jars is another way to prevent cross contact. We also talked about going to restaurants and what that looks like for somebody following a gluten-free diet. So some strategies to make this a little bit more successful for the patients and their families. See if they can call ahead, maybe look online at menus beforehand and try to request the same types of precautions that we were just talking about, maybe in a home kitchen environment in the restaurants as well. And so specifically asking questions around food preparation, such as shared fryers, heating up pasta, maybe separate pizza shops or stations and marinades and dressings that could have some sneaky ingredients. And so trying not to assume that restaurants know how to deal with cross contact. I think always asking these questions is in for benefit of the patient. We also talked about strategies for managing social events, especially working in pediatrics. I feel like this is something that comes up a lot in clinic visits. And so talking about keeping gluten-free food separate and serving gluten-free food first, avoiding shared utensils, maybe bringing your own dish to share in a situation where you might not know if a gluten-free option is available. And I would say the biggest key takeaway that I try to leave with families is trying to be proactive and plan ahead for these situations as well. We also talked about teaching patients about hidden gluten, and we talked about it from a food setting in terms of some of those products that might not come up as typical grain-based foods, but then also non-food items and being mindful of how hypervigilance can impact quality of life. So really trying to find that balance of, these non-food items have gluten in them, but at the same time, if we're washing our hands and being mindful, then the gluten's not jumping into your mouth to be digested. It's something that can be managed and be mindful around it. And really trying to reinforce that concern that it's really only a concern when gluten is ingested. Some tools for reinforcement that we reviewed. So 504 plans to support children while they're at school, regular nutrition follow-up with the celiac expert dietitian, being a resource for patients and families in clinic, trying to double check ingredients, and then real-time examples of ingredient lists for practice in that follow-up setting can be helpful for both patients and their caregivers. I'm going to shift gears a little bit into just some papers about diet quality and kind of some thoughts around the gluten-free diet quality. And so, I think that if a gluten-free diet is not followed intentionally and with the right education, it can be low in fiber, higher in saturated fat, added sugar, lower in vitamins and minerals. There can be an increased risk of cardiovascular disease, constipation. It can be socially isolating. There can be a risk of increased arsenic levels. It can be anxiety provoking, expensive, and have limited variety. So all the more, I think, important to work with celiac specialized dietitians to ensure that patients and families have the education and information that they need to avoid these types of situations for their diet. But we know that for gluten-free diets, metabolic or patients with celiac disease following a gluten-free diet, metabolic syndrome is a concern. So metabolic syndrome includes various factors. It increases the risk of chronic diseases, so type 2 diabetes, high blood pressure, dyslipidemia, fatty liver, and obesity. And so those following a gluten-free diet might be at higher risk, just where foods can tend to be more hypercaloric and higher values of saturated fat, added sugar, and sodium. So how do we balance that? How do we educate on that? What do we want? What messages do we want to deliver to patients to avoid, putting them at risk for metabolic syndrome? So encouraging a gluten-free diet that's rich in foods that are naturally gluten-free, and really with an emphasis on reducing intake of ultra-processed foods. So really focusing on increasing nutrients that just support overall balanced nutrition, pulling foods from all of the food groups, and really focusing in on fiber, lean proteins, and omega-3 fats. And then lastly here, just going through economic burden with the gluten-free diet. And so thinking of it from kind of this multi-layer perspective, there's societal perspective, where for people with celiac disease, if they maybe were accidentally glutened and miss a day of work, miss a day of school, they're absent, they lost some productivity. And then the healthcare system perspective, if there are patients and who maybe are not feeling well and utilizing healthcare resources or additional medications, and then for the patient perspective, the cost of groceries. So all of these different layers kind of contributing to economic burden for this population. And so there is at least 139% more expense to gluten-free products in the US. And there was an abstract that I found that I just wanted to highlight that I thought was really striking, showing that gluten-free breads on average are 4.59 times more expensive by ounce, and gluten-free pastas on average are 2.7 times more expensive by ounce. And these were at some major grocery stores in the United States. So all of these topics, kind of reviewed over the course of the day, and just an overview of all different impacts on the gluten-free diet. Again, it was an honor to be a part of the day. So I'm going to now pass it over to Sharon to walk us through the poster sessions of the Single Topic Symposium.
Thanks, Jacqueline. And thanks for that great overview. Let's see, I'm just going to share my screen. All right. So I'm just going to present some posters from the poster session, and there were so many great posters, this really doesn't do justice. We're only going to cover a few tonight, but the first one that I wanted to just highlight was on the topic of culinary medicine, and this was presented by Vanessa Weisbrod and the team from Celiac Disease Foundation. And this had to do with culinary medicine used as a tool to enhance provider confidence in managing the dual diagnosis of celiac disease and type 1 diabetes. And so just as an introduction, culinary medicine is an evidence-based field that blends medical, nutrition, and culinary knowledge to support patients in maintaining health and treating chronic disease. And we know that the dual diagnosis of celiac disease and type 1 diabetes requires significant dietary intervention to effectively manage both of those conditions. And so the aim was to really determine whether participation in a culinary medicine program can improve confidence of physicians and also dietitians in counseling patients with the dual diagnosis, as well as knowledge of appropriate dietary interventions. And so the methods that they used were to they developed a pilot web-based series that was accredited for CEUs for both physicians and dietitians. And this was on the topic of the dual diagnosis. and they used pre and post surveys to determine changes in confidence related to counseling patients. And so what they found was integrating the culinary medicine program into continuing education seminars can significantly improve provider confidence in counseling patients requiring complex dietary interventions, such as the dual diagnosis. The most common diet education strategies they found used in this sample were focused on balanced meals and snacks, and also low glycemic foods. And provider confidence significantly increased after the webinar compared to baseline. And also they found that 29 healthcare providers claimed CEUs, 62% learned a new skill to incorporate into their clinical practice. And again, provider confidence was significantly increased. The next poster that I want to present also was done by Vanessa Weisbrod and the CDF team, and also University of Chicago. And this had to do with navigating celiac disease in college. Results from a national student survey on dining, housing, and support services. And so just as an introduction, we know that college presents unique challenges for students with celiac disease. And really, despite increased awareness of food allergies and dietary restrictions, there's limited data that exists on how students navigate celiac disease during their time in college. And so the methods that were used were they conducted a national survey between March and April of 2025, and this included 35 questions that explored student experiences with dining and housing and support services, social experiences, and also mental health. And the responses were solicited via the foundation's email and also social media platforms. And the results that they found included a total of 324 students that completed the survey. Survey respondents represented a diverse academic setting. 54% were attending public universities, 41% private, 5% community colleges. A majority, over 50%, lived on campus in on-campus housing, and 55% participated in a college meal plan. However, they noted that campus dining posed significant challenges. And so of the findings that they showed, out of dining and safety and confidence, only 7% felt confident that the food was gluten-free, 60% either not very confident or not confident at all. Regarding dining hall use and satisfaction, more than 60% expressed dissatisfaction with the variety of gluten-free options that were available. With regards to mental health and food access, 63% experienced frequent stress or anxiety about managing their celiac disease on campus. 90% reported skipping meals because there were no safe gluten-free options. And 53% avoided social events because they were concerned about food safety. And then with regards to disability accommodations and support, only 32% of students had even registered with their school's disability services. Among them, only 20% found the office to be helpful. And then perceived campus support, only 4% felt that their campus community clearly understood or was very supportive with regards to celiac disease. So in conclusion, the high rates of gluten exposure, meal skipping, and also stress underscore the need for policy-driven solutions to ensure equal access to food and health and education for this population. And so institutions of higher education need to improve gluten-free safety protocols, housing, flexibility, and clear disability accommodations to support the well-being of students with celiac disease. All right, the next poster that I wanted to highlight had to do with the Gluten-Free Buddies program. This was done by Hillary Jericho's team out of Stanford. And this was a pilot peer-to-peer mentorship program for youth with celiac disease. And so just background information for this poster. So youth with celiac disease often experience higher rates of depression and anxiety, and also a reduced quality of life. There are peer mentorship programs available that have been shown to benefit youth with chronic illnesses, but not with regards to celiac disease yet. And so this study aims to develop and pilot a peer-to-peer mentorship program for youth with celiac disease. So the methods for the Gluten-Free Buddies program was a 6-month peer-to-peer mentorship program for youth aged 13 to 25 with celiac disease. And participants were recruited via community and patient email databases. They were invited to join either the intervention group, consisting of peer mentor training, monthly meetings, and safety check-ins, or a control group. And participants in the intervention group were matched with a peer mentor based on their age and also their interest to foster stronger peer-to-peer connections. Both the intervention and the control groups completed validated surveys to assess gluten-free diet compliance, also psychosocial well-being at baseline 3 months, 6 months, and 8 months. And the intervention group also completed a feedback survey at the 6-month time point. Standardized mean differences between intervention and control participants were calculated, and descriptive statistics were calculated, and an equal variance to sample t-test was performed for the primary outcomes at the 6 and 8 month marks, and the feedback survey responses were then analyzed quantitatively. And so the results included 92 participants. The mean age was about 17 years, and 42 in the intervention group, 50 in the control group. 60% of the program participants completed the 6-month feedback survey and 68% the 8-month survey. And while participants were not randomized, standard deviations were small, and at 6 months, the peer mentorship group showed statistically significant improvements in gluten-free diet adherence compared to the control group, as well as positive trends in depression, quality of life, and also psychosocial well-being. There were no statistically significant group differences in peer relationships, resilience, or global health, and participants reported higher satisfaction with the program and their peer mentor match, and most were very likely to recommend the program to others. So in conclusion, this really highlights the potential of peer mentorship to be a valuable complement to clinical care for youth with celiac disease. And this pilot study has established a strong foundation for future iterations and a broader programmatic efforts, and participant feedback will guide targeted revisions to the program and include enhancements to mentor training and also strategies to foster sustained engagement and the long-term impact and scalability of the program. And then finally, the next poster that I would like to just go over, also done by Hillary Jericho and the team from University of Chicago, as well as Stanford. And this explored the financial and psychosocial dimensions of the gluten-free diet in celiac patients. And so just background information for this poster, again, we know that strict adherence to a gluten-free diet is the only current treatment for celiac disease, but it's not covered by insurance despite functioning as essential therapy. And so this cross-sectional pilot survey aimed to quantify the financial and psychosocial burden of the gluten-free diet on patients and families with the goal of establishing a framework for insurance coverage of medically approved gluten-free foods. And so this was a prospective study that included 2 groups, 16 case families of children newly diagnosed with celiac disease, and then 16 control families that had been diagnosed for at least a year with celiac disease. And the case families completed a survey on demographics, changes to grocery lists over time, and also psychosocial impacts of adherence to a gluten-free diet, in addition to standardized perceived stress and food insecurity questionnaires at diagnosis and also 4 weeks after starting the gluten-free diet. They also submitted 5 grocery bills, pre-gluten-free diet, and then at 2 weeks, 1, 3, and 6 months after starting the diet to assess changes in cost. And control families completed the same surveys. They submitted at least 1 grocery bill at the time of enrollment, and then participants were recruited via email through the electronic medical record review, and they completed surveys using REDCap. And so the results showed that 32 participants with celiac disease were enrolled, 16 newly diagnosed, 16 on a gluten-free diet for at least a year. All control participants completed surveys and they submitted at least 1 grocery receipt. And among the newly diagnosed participants, 12 completed at least 1 survey set, 7 completed both pre and post gluten-free diet surveys, and 9 submitted at least 1 grocery receipt. 2 completed all study components. And in the newly diagnosed group, they perceived stress appeared to decrease. The perceived stress appeared to decrease slightly after gluten-free diet, while the control group reported significantly lower stress levels. Food insecurity scores were high in the newly diagnosed group, and they remained elevated in the control group. Grocery data indicated an initial increase in spending on processed gluten-free products with a subsequent shift towards naturally gluten-free foods. A gluten-free diet was also approximately 11% more expensive per unit than a gluten-containing diet, which corresponded to an increase in $666 in annual grocery costs. And so in conclusion, this study of families managing pediatric celiac disease showed perceived stress that decreased significantly after a year on the gluten-free diet, including which indicated improved coping over time. However, food insecurity remained prevalent, and the gluten-free diet continued to cost more, and approximately 11% more per unit than a gluten-containing diet. And although families showed a gradual shift towards using more naturally gluten-free foods, there was still a financial strain and barriers to food access that persisted even within a well-resourced clinical environment. And so these findings really support the need for a policy framework that enables insurance coverage of medically approved gluten-free foods to reduce the long-term economic burden on affected families. And I'm just going to, I'm going to stop sharing and pass it on to Jackie. Let's see.
Thanks, Sharon.
All right. Let's see. Oops. There we go.
Okay. You can see my slides? Yes.
Yeah.
So we had a really exciting opportunity at NASPGHAN this year that celiac disease was selected after the very hard work of our course directors to be the Single Topic Symposium, which is a one-day symposium prior to the start of the annual meeting that highlights one particular disease. So this was very exciting, some long overdue attention for celiac disease at NASPGHAN, and we had a full day of really, really wonderful talks. I had a very hard time picking out the ones to highlight, and I see a lot of our speakers from that topic, from that symposium are here tonight, so hopefully I did everyone justice. I tried for this audience to focus a little bit on some of the highlights that included data that was newer over the past year or two, as opposed to some of the older data that we may be familiar with. So first, Dominica and Ed engaged in the classic debate regarding biopsy confirmation versus non-biopsy diagnosis. Somehow this topic never gets old, but she presented some really nice data from Dr. Singh and colleagues, which surveyed NASPGHAN members across the country, asking about their practices with non-biopsy diagnosis. And these are the results that showed that 47% of providers are using only endoscopic diagnosis. And then 39.6 were using serologic criteria if the patients were symptomatic, indicating a pretty close split in practice throughout the country, with a much smaller proportion of people choosing just serologic criteria only or without any criteria. So I think this was really interesting to see what's happening for real out across the country. She also discussed the application of the NASPGHAN criteria in patients with type 1 diabetes. So in this study from Cincinnati, they conducted a single center retrospective review looking at 123 patients with type 1 diabetes that had endoscopies for possible celiac disease, and looked for factors associated with actual diagnosis. And they found that for every 10-fold increase in the TTG-IgA, there was a 4.7 times increased risk of celiac disease, and that the positive predictive value of a TTG-IgA greater than 10 times the upper limit of normal was about 85% in this group. So performs a little bit differently than it does in the general population. But then they also looked, excuse me, they also looked at EMA, and they found 4 patients who met the NASPGHAN criteria but had a negative biopsy for celiac. 2 of those went on to develop celiac at a later date. But when they looked at the dilution of EMA, they found that if there was a TTG 10 times the upper limit of normal and an EMA with a titer over 1 to 80, the positive predictive value raised to 100. And so I think in an era where some have started to consider whether or not EMA has ongoing utility, and that's been a debate that came up here and there over the course of the symposium, this is an argument for its ongoing use, especially in some particular cases. Excuse me. Then there was a really nice talk by Dr. Edinger about clinical dilemmas in celiac, discussing when there's mismatch between labs and symptoms and biopsies and when they don't line up. He highlighted this nice study from Kruger and colleagues published earlier this year that looked at the co-occurrence of celiac and DGBIs in kids. And they had 191 pediatric patients on a gluten-free diet and found that 43% of them met the Rome-4 criteria for a DGBI, mostly functional constipation and functional abdominal pain. And this, I think, highlighted a lot of what we see in clinical practice, that there's a lot of overlap between celiac and the DGBIs, and that figuring out what's secondary to gluten-free diet adherence and what isn't remains an ongoing clinical challenge. He also highlighted a similar study that was done, this one in adults, that looked at clinically related events, which they defined as signs or symptoms that required a diagnostic or therapeutic intervention. And they looked at 189 adult patients and found pretty common ongoing symptoms in 48%. Only 4% were deemed to be from poor gluten-free diet adherence, and the most common of these clinically related events were found to be functional disorders, and that was in 30%. So the biggest chunk were in functional disorders, followed by reflux, which was found in 18%. And then lastly, he reviewed these exciting results from Australia, which are looking at the development of a whole blood assay for IL-2 to assess for celiac disease, especially for those on a gluten-free diet. And these really nice, promising results, which I think we highlighted in our newsletter, I think, showed significant differences in IL-2 after gluten peptide stimulation in treated celiac disease, which you can see in the dark blue, versus active celiac versus healthy and then non-celiac gluten sensitivity. So I think this has been in the works for a very, very long time. So it was nice to see some of this updated data presented to the group as a whole, and I think was really a nice way for the celiac community to show a lot of the general pediatric gastroenterologists in the office that there is new and exciting stuff coming down the road for celiac disease. And I think that was one of the real benefits of the single topic symposium, is we got to hear from a celiac specialist standpoint some of the relevant questions that the general pediatric gastroenterologists had to ask, and they were quite different from what we often hear in celiac specialized groups. But it was really nice to share some of this exciting information for moving forward. And then just one quick pharmacotherapy update. So Dr. Sylvester presented some insights from ongoing clinical trials. She shared this phase 2 data from the TAC-062 phase 2B study. Here is the clinical trial design below, but what I wanted to highlight on this slide was actually in the upper right-hand corner, which is the development of the siege bar, which is a kind of standardized gluten load in a palatable form, and similar to like a granola bar. And so they can use gluten-free bars during the run-in, and then this siege bar, which is standardized and easier to use than some of the previously used like flat gluten flours. Unfortunately, the study itself didn't show any significant difference between the placebo group and TAC-062 from their primary endpoint, which was changes in the CDSD. And there was also actually a worsening of villus height to crypt depth ratio in the TAC-062 group compared to the placebo group with the gluten challenge. So this study was discontinued after the first cohort in phase 2B, which was a little sad because I believe they were planning on enrolling adolescents in the second cohort. So we'll have to see what happens next for this and for the class of enzymes. But again, taking out of this, we learn with every study like new pieces of information on how the best way to conduct clinical trials in celiac um, is developing. And so the siege bar came out of this. And then I'm going to hand it over to Telly.
Okay, great. Cool. Thank you, Jackie. Let me share my screen. Does that show? That shows okay. Okay, great. Thank you so much, Jackie. Yeah, I'd like to continue to focus on some of the takeaway clinical points from this single topic symposium that resonated with me, and focusing on part of the epidemiology, some of the therapeutics, some new information to guide screening in North America. I'd like to just also recognize some of our course directors that made this single symposium available. So Dr. Tamara Hajjad and Dr. Maureen Leonard, thank you for making this happen, and among many others here, actually. So one of the articles that I wanted to focus on first was one presented in a number of talks throughout the symposium day and NASPGHAN meeting. This is initially presented by Dr. Benjamin Lebowal from Columbia University. This is an epidemiology type of study, and for us, it's a way for us to understand the change in the incidence of celiac disease over a long period. So this is published in American Journal of Gastroenterology in 2020 by Dr. King and their team. And if we look at the x-axis and the period from 1950s to about 2020, we see that overall, looking here, a limited subset, but looking at some of our industrialized countries, overall, an increase in the incidence of diagnosed celiac disease. The y-axis here uses a metric of incidence, a measure of it. I think for our purposes, effectively is looking at new cases. And we think that over time, and if we follow each color, allows us to follow one country, and looking at comparing colors is a way to compare countries as well. So I think it's a really nice way to look at the change of celiac disease incidence over time. Another way to look at this that's also in this article is one focusing on our pediatric celiac disease group, and we'll look at the adult study or adult part of this table as well. What we find here, and I'll draw our attention to the bottom right, is we're looking at the incidence of pediatric celiac disease over this period of time among these countries. And if we take these studies together, we find that the incidence in here quoted is 21.3, a rate of 21.3 per 100,000 person years. That is an epidemiology term. I think for our understanding, if we compare this number, 21.3, to our adult data, and I'll draw our attention to the bottom right, 12.9, using the same units, is that in pediatrics, we have roughly, and it's a rough estimate, about twice as high of incidence for the diagnosis of celiac disease. And then that gives us a little bit more of a historical way to understand as pediatric gastroenterologists as well as adult gastroenterologists when celiac disease presents in our clinic. So I thought this is a really nice way for us to see that visually and then in a more classic forest plot format. I think as Dr. Lebowal had mentioned, some of the limitations of this study is that this is focusing, as you see here, on a number of industrialized nations described in the article. It does not represent Africa, Asia, Latin America. So there is only some of the data that we're able to see. And other parts of this article that was important is that we believe, one, the incidence is rising because we believe we're getting better at the diagnosis. But as part of this phenomenon, we believe it's not just that. There are some environmental and genetic factors as well. And throughout the talk, or throughout this symposium talk, there were just hypotheses about the amount of gluten consumed, exposures to antibiotics, other hypotheses about hygiene. specifically as we've seen quote unquote just cleaner environments that decreased exposure to microbes over time may prompt our immune system to maybe higher activity later in life. As part of the hypothesis, maybe that explains a number of GI diseases and celiac diseases in that as well. Another talk of interest presented by Dr. Arunjit Singh from CHOP is an article that was published in JPGN in 2023. Dr. Singh reminds us of some of the clinical scenarios that are useful for a gluten challenge. And specifically, if we look at this figure presented by Dr. Singh, there are three large categories of which the denominator common among all of them is they're all on a gluten-free diet, and we're not quite sure if there's a celiac disease diagnosis, and that's where the clinical tool for a gluten challenge comes in. So in the first scenario on the top row, for those that are potential new diagnoses, so with positive serology that are less than 10 times upper normal limit, have not gone a biopsy yet, but are already on a gluten-free diet, these are clinical scenarios where potentially a gluten challenge would be useful to confirm celiac disease. A second scenario is among patients that have symptoms when they're exposed to dietary gluten, but not necessarily serology yet, and they've already started a gluten-free diet. So this is another category that Dr. Singh reminds us is a useful scenario to do a gluten challenge and differentiate celiac disease from potentially other gluten-related disorders. Lastly, another scenario are those with potential celiac disease, those that have positive serology, previously normal endoscopies, so have gone through the diagnostic process, but there wasn't a definitive biopsy sample that suggested celiac disease. And these are patients that may have started a gluten-free diet. This is a scenario that may be useful to do a gluten challenge potentially later in life, especially if we've gone through puberty, to identify that potential progression to active celiac disease. The team that had composed this article had recommended 3 to 6 grams of gluten ingestion daily for 12 weeks as a general guideline. And there are multiple variations to that based on symptoms and or tolerance to gluten. They do recommend that longer duration and higher doses may allow better diagnostic yield. I thought also really useful, at least in clinical practice, for myself at least, is this table that they present. This is not an all-inclusive categorization of how much gluten that's in different food groups, but I thought for me at least, this is nice sometimes to give a concrete way for families for me to describe for families, like, okay, this is this amount of gluten, and this is the serving size, and these are different categories that we can represent. I'll lastly mention that a component that came out of this article is that 4 to 6 week mark is an essential time where an assessment of symptoms allows us to adjust dose and also the duration of the gluten challenge. Those that are symptomatic might need a smaller dose and a shorter duration. Those that are not symptomatic may do better with a higher dose and a longer duration. And I think ultimately this article focused on tailoring that gluten challenge to the developmental age of the child, their stage, their pubertal development, and their symptom severity. So as a clinician, I thought this was a really nice article to summarize that practice. As Jackie had mentioned, alluded to it a bit, and Dr. Edwin Leo from Colorado, as well as Dr. Dominika Gildewitz had talked about this debate about the use of TTG-IgA and serology in general as a diagnostic approach for celiac disease. They both presented this article, and I highlight our eyes to the second row. This is the largest retrospective multi-center cohort study that was just published in Pediatrics in 2025. What it does is it gives us a lot of useful information, at least in North America, to understand the positive predictive value of TTG-IgA. And they looked at over 4,000 children. They looked at multiple centers throughout the US, and they looked at different assay types that are spread out across the US used to look at TTG-IgA. And what they found is that TTG-IgA greater than or equal to 10 times upper upper limit of normal, gave a positive predictive value of 95%. There were a number of assays described in this study, of which right below that number is a range of their positive predictive value. I thought this article is useful for us as clinicians to reference, as not every assay is equal in their positive predictive value. For me at least, it's useful for me to look at what are the assays we have at our center, or at least associated with our center as well, and looking at what the range of positive predictive value is. Notably, if we look at the patients that also had an EMA with that TTG IgA greater than 10 times upper normal limit, we find that if it's positive, it's about a 1% increase in that positive predictive value to 96%. What I'd like to briefly highlight next is, what does that mean? What does 95% mean to a normal person? To summarize really is, this is a slide presented by Dr. Liu, but effectively we have 100 patients. Say we start with 100 patients and they come to our clinic. We are to our pediatric GI clinic. And I say that specifically as this study looked at pediatric GI centers. So the prevalence of celiac disease may not be equal at a pediatric GI center versus a general pediatric office. But at least in the pediatric GI center, if we look at, say, 100 patients, and they all have positive serology greater than 10 times upper normal limit, 95% of the time, if we guess celiac disease and guess that their biopsies would be consistent with celiac disease, we'd be right. 5% of that time we would be wrong. So simplify that proportion, it's about 1 in 20 patients if we use this serologic diagnostic criteria, would be wrong 5% of the time. And so the question, and that's somewhat of an individual question for each center and each clinician, is diagnosing celiac disease using only serology correctly 95% of the time or 96% of the time with EMA good enough? And that's where part of the debate is. This I will try not to focus too much time on for time purposes, but this is presented, or at least this article was the premise for Dr. Joe Murray's talk on potential therapeutic targets in celiac disease. I'll just bring our attention to this article published in Gastroenterology in 2024. What it does really nicely is highlight the current therapeutic targets that a number of clinical trials are working on. And what I do here is just using part of the article as a framework. I highlight some of the therapeutic categories that are currently being targeted. First, and I'll backtrack one is, and this is based on our understanding about the pathophysiology of how dietary gluten is exposed into our bodies, into the small intestine, and how that immune reaction ultimately goes from outside and the lumen space of the intestines through the cells, in between the cells, into our intracellular space, and the immune reaction occurs, of which we then look at some of our, which manifests with some of our serologic screening parameters, and in addition to that, the findings we see under a microscope. So first are intraluminal therapies. Things that were described are, for example, glutenases. These are generally exogenous enzymes that are meant to degrade the gluten peptides that are metabolized in the body. In addition to that are gluten binders. So binding the peptides before they enter the intestines is another type of therapy. Another component commented on are transepithelial uptake medicines, specifically those that target the tight junction or the some of the space between the cells of the small intestine. We believe that gluten in the correct setting causes an immune reaction that leads to that increased permeability from intestines into our cells. This medicine type is meant to target that and actually decrease that permeability. Others commented on in this talk were biologics, meant to reduce the inflammation produced from the immune reaction to gluten. Others are focused on dampening their active immunity of the body, specifically targeting some of the enzymes that are in our cells that are part of that immune reaction for gliadin and glutenin that enter into the body. HLA blockers are another type of mechanism within that dampen adaptive immunity class, meant to block some of the, or lack of words, block some of the Lego pieces that are important in that immune reaction. And then lastly, immune modulators, very interesting, help us induce tolerance. That is a very interesting type of therapy I would love to see progress forward. As I talk about therapies, one other thing that was of focus and interest in this talk was presented by Dr. Shayna Coburn. And they have done fantastic work at Children's National Hospital, developing a multi-center celiac disease team that includes a psychologist. And this article presented by them looks at ways that we can better assess the psychology of having celiac disease. And these are some of the questions I thought were really useful, at least for me, to incorporate into my practice, of which includes what is it like to be gluten-free, what is the hardest thing about gluten-free, and et cetera. I'll refer you guys to the article that they published in 2019, but this goes through more of their questions that they ask in the psychological assessment, which I thought very useful. Lastly, what I'll highlight is a poster that I presented that looks at the association between neighborhood socioeconomic deprivation and the change in normalization of TTG-IgA in pediatric celiac disease. This is a single center study at UCSF, and what we looked at were about 207 children less than or equal to 18 years old with serologic or biopsy diagnosed celiac disease. We used an community-based census tract indice to measure their level of neighborhood levels socioeconomic deprivation, and we looked at how fast their TTG normalized over time. And I think the big takeaway is that if we divide this indice into quartiles, higher quartiles meaning indicating higher deprivation, and we take that relative to the least deprived, so Q1, so Q4 over Q1 would be the ratio we're looking for in the purple column. We see that among those that are most deprived relative to those that are least deprived, there's about a 50% reduction in the rate of their TTG-IgA normalization. In other words, this is to say it takes twice as long for their TTG to normalize. And if we account for other components that may factor into normalizations, such as race, ethnicity, language, and insurance type, that rate goes down to increases to 67%, or excuse me, decreases. The rate reduces by 67%. So it's about 3 times as long to normalize. So this is a way for us to understand how serology changes relative to deprivation. And I think that is my last slide. And I will pause there.
Kelly, if you want to keep sharing your slides, we can just go over the last 2.
Oh, of course. Yes, happy to. Okay. Please take it away, Sharon.
Okay. So just in closing remarks, we have more upcoming webinars that are going to be happening every month, starting in January. The next webinar is January 20th, and that's going to be supporting young researchers. We are going to be shifting the time of our webinars to during the daytime. So you can find more details on the exact times of the upcoming webinars and all of the different topics on the SSCD website under the education tab, and just click on webinars. Most of the webinars are recorded and posted on the website, and also will be available for CMEs, CEUs. And we also wanted to say thank you to the webinar committee and the SSCD Council. And then the next slide. All right, and for those who are not members yet, please join SSCD. This is open to medical, scientific, and allied health professionals, and there are many benefits, and you can just snap the QR code, and that will bring you to how to join. All right, and thank you, everybody.
Thank you.
Thank you.
So if anyone has any questions for the speakers, I think we can stay on for a few more minutes. We are right at the hour mark, but if anyone has any questions, feel free to come off mute and ask directly to the speakers. No? Okay. All right. Well, in that case, oh, Jackie, were you going to say something?
Impressive timing, you guys.
Yeah.
For the fact that we all prepared the slides separately, the fact that we ended on 9 on the dot is kind of amazing.
I know. And it looks like most people have dropped. So hold
Yeah.
on. I'm going to stop
Yeah.
the
I think it
recording.
was just Kate that was stuck in here for the last minute. Yeah.